My name is Hassane Zarour. I'm a dermatologist, a sick patient at the Melanoma Center here every Friday. I have also, for those who are interested, a free screening every third Friday of each month. So if you or your parents would like to come, you are welcome. That's basically to do early melanoma detection in patients who have some concern. So I would like to review today, and thank you for giving me the opportunity to talk basic information about early detection in melanoma. I'm sure that most people in the room knows, but let's review basics, important things, and okay, so next slide, yeah. Just, so Valerie talked about it a little bit, but just review some information, underlining the fact that the incidence of melanoma is rising. In 2010, there was more than 63,000 new cases of melanoma, and unfortunately, 18,700 deaths in the US. So there is a rapid increase in melanoma. In men, the increase is more than any other malignancy in women, more than any out of lung. So that's really a disease which incidence increase a lot. Median age is 59, and we know that it's very important to detect this as early as possible. Because if you, depending on the depth of the melanoma, the prognosis can be really very, very bad. Next slide. So the question is, who's at risk? Who needs to be followed very carefully? So we know now there is a number of risk factors that are well defined. Having multiple so-called atypical or dysplastic moles is an important risk factor, and I'm going to come back to that later on to talk about this notion of what you call atypical or dysplastic, because I just realized that in patients there is a lot of confusion about that. Having a fair skin and an inability to tan is also a risk factor that really increase the risk of melanoma. The personal history of melanoma is also, so when patients have a melanoma in the family, really this increases the risk of melanoma for the other member of the family, and if this member, like it is often the case, have multiple more, they really have to be follow-up and go and see on a regular basis a dermatologist. So family history of melanoma, so we know that there is some genetic mutation. Sometimes it's rare, but a percent of the population have this mutation, and then there will be melanoma from generation on generation. So it's rare, but in this case, you can really define if these people carry the mutation, and we know that we have to follow carefully this population. There is a number of studies that have shown that having severe sunburns in your history, and maybe during childhood, was an important risk of melanoma. So that's bring something important in terms of prevention, meaning limited sun exposure, not only for the adults, but starting very early for the kids. This seems to be extremely important. Cumulative UV radiation, so the total exposure to sun UV, this is an important factor. This is another reason to limit sun exposure. The large congenital nevi, so we know that you can be, some kids are born with moles, and some are called congenital, so when you are born with that, and the large one present a higher risk of becoming a melanoma. So when they are large, most part of the time we recommend at some age to remove them. This is an important risk of melanoma. And we know that some people with some immune deficiency, transplant people with HIV disease have an increased risk of melanoma. So what to do? How to suspect a melanoma? So when the patient comes, what are we going to do? So mainly the diagnosis and the suspicion lays on the clinical signs. So that's what I'm going to remind you today. Dermatologists have tried also the techniques like dermoscopy, looking with a lens, and trying to find signs that would suggest melanoma and would preclude to do the surgical excision. But I think this, I'm not really a big supporter. I think it's an interesting method, but the bottom line in the end is, well, you have a doubt, and some says that you end up doing the biopsy. So that's Over the past years, a number of techniques have been brought and tried, like a confocal scanner, scanning laser microscopy, some imaging technique, or spectral imaging, to try to see if the diagnosis can be done benign versus malignant, and avoid excessive surgery, surgical excision, which is, I'm going to talk about that, sometimes a problem in the clinic that we are facing. Some patients come with a dozen or sometimes 100 moles that looks atypical or funny, and have to go through surgical excision after surgical excision, and there's a lot of stress. Why I have to stop? That's and I'm going to come back to that later. So what are the clinical signs? Next slide, please. So just to remind you that the melanoma and the moles come from this, are derived from this melanocyte, these cells that are at the basal part of the epidermis. They are important because they produce pigment that protect you from UV. Next slide, please. So these are regular moles. That's from this patient. Usually the moles are small, are well delimited, are symmetric. Next slide. This is an example of what I was talking about, congenital mole. So this is a large one. This is really a very large one, and we know that when they are extremely large, they present a risk of becoming a melanoma one day. So as much as we can, we try to remove them. Next slide. This is a blue nevus. This is a benign nevus. We call it blue because it happens really under the skin in the dermal part under the epidermis, which gives this funny aspect, blue nevus. But this is benign. Next slide, please. So what we call atypical or dysplastic nevi, this is type 1 nevi. So usually a mole is regular in shape, is small, has one homogeneous color, and has regular border. And some patients come with this, and sometimes they have dozens of these ones. So there is not one color, but there is multiple color. They are larger. They are a little bit asymmetric. That's and the border a little bit irregular. So, and that's where the problem starts, because if you have one more like this, the problem is easy. We have a duct, we remove it, and that's the end of it. The problem is when people have multiple of them and have them removed. The diagnosis come dysplastic nevi, and that's where the problem starts. In a lot of people's mind, dysplastic means precancerous, and in terms of melanoma, that is not the case. Dysplastic is histologic features. When the pathologist look under the microscope, basically all the clinical signs that I'm talking about, the equivalent in terms of histology, are that the cells, instead of being very small, are a little bit larger. The architecture of the lesion, instead of being well organized under the microscope, is a little bit disorganized, and so they call that dysplastic nevus, dysplastic mole. But doesn't mean that this is a precancerous lesion. And that's there's a lot of confusion in patient mind where they become scared and say, oh, I have a precancer, what should I do? I have a dozen of that. And we'll talk about that later on. So not all dark tumor and pigmented tumor and raised tumor are melanoma, and this is an example of seborrheic keratosis, which is extremely frequent, and that every dermatologist would recognize very easily, and we don't need any surgical excision. So that's why maybe the expert is important. Next slide, please. So what are the important clinical signs that in front of pigmented lesion, we tell you this is a melanoma? So we have the classic A, B, C, D, I just talked about, meaning the lesion is, instead of being symmetrical here, so is asymmetrical, as opposed to a regular border. The border are going to be irregular. The diameter, which is going to be larger, and I think one important factor is the change. And that's what I try to insist with patients. Sometimes, what is the history of the pigmented lesion? So, and my feeling is a mole shouldn't change in the adulthood. In childhood, it's normal, you grow and a change is possible. They can grow in size, but then in the adulthood, I find suspicious to have a new mole coming, a new mole growing, and only this sign, in my experience, will push me to say, oh, that's something I want to remove. And the change is very important. So when somebody has a lot of, we have talked about atypical mole, well, it's difficult because now they are, irregular, they are large, and people worry about that. So that's where the collaboration between me and the dermatologist and the patient is going to be important to try to follow up clinically, sometimes with imaging, or to get a notion of what has changed, what has appeared, if a new one has appeared, or extended, change in color. And on this specific mole, we try to be more aggressive and perform an excision biopsy to send that to the lab, to the pathologist who is going to look into that. So this is an important notion in the clinic, and that's in my own practice. When I have a duct, the only way to find out is to remove it and to send to the laboratory for pathological analysis, where the pathologist is going to look at the lesion. So, and now there is different opinion. A lot of dermatologists what they do is shape biopsy. So basically, they just make an anesthesia and just remove the superficial part of the skin. It's easy, you don't have to put stitches, so I understand it's very convenient for the patient. The big problem with that is when you have a suspicion of melanoma, it is important to have first a tissue the integrity of the tissue is extremely important for the pathologist. You don't want something to be damaged, traumatized by the shape biopsy. The also important things is for the pathologist, let's say it's a melanoma, to have the full depth of the lesion. When you do the shape biopsy, you don't control that. You may cut a part of the cut may be in the middle of the lesion because it's visual, you cannot see that. The advantage of the external biopsy, you're going to remove the full lesion. So the pathologist who has something very, very clean, will be able, if it's a melanoma, to let you know not only that it's a melanoma, something that has not been traumatized by the shaving, but to be able to talk about the depth, which is an important factor. So that's why I really encourage and discourage people when they have to have a mole removed because it's a suspicious melanoma. I would really discourage the shave biopsy. If it has to be removed because there is a duct, let's make a classical excisional biopsy. So next. So these are other examples of melanoma. So and you have all the criteria here, large, multiple color, irregular border, and here what we call sign of regression. The pigment disappear, and this means that we know that at this level we will find some immune response. Under the microscope, we will find some T cells, white cells that are here infiltrating and attacking the tumor. So these are other type of melanoma. Yeah, to give some example. But here there are really a little doubt about the diagnosis. So these are something that unfortunately we see less and less. That's a tumor that are already raised and pretty big. Next slide, please. Okay, some examples. So the melanoma can also reach and lay in the nail bed, which is a problem because you have to make a biopsy at this level, which is tricky, which maybe sometimes is the intervention of the surgeon for that. Next. Yeah, that's some patient may have a lentigo, so pigmentation, which where melanoma can develop. Okay, so the dermoscopy. So I think the basis of the suspicion lays on the clinic. Now a number of dermatologists practice dermoscopy, which can be helpful. This is and basically they look under this lens and have some sign that may tell them it's a melanoma instead of being a seborrheic keratosis, the black tumor I showed you before, or a vascular lesion like an angioma. So this sometimes may be helpful. So what we do also for the people who have a lot of mole, where it's really difficult sometimes to follow up, you can propose a whole body photography. And what you do with a photographic picture of parts of your body that you kept on the computer. And that allows us, when the patient comes, with dozens of pigmented lesions to compare part of the body compared to part of the body and see really if change occurred. If the patient had new pigmented lesion or if some lesion have changed. That's another approach to that, which has some also downside of it, because if you want to do that really carefully, it's really time consuming. People who have dozen of pigmented lesions, you really have to sit down and do that. So in practice, I think it's very interesting, it's very important. Practically, it's also very time consuming, so you take the picture, you see, have the time to review them carefully every time the patient comes. That's good. Next. So, how to make the diagnosis? So this is pathological diagnosis of melanoma, so we need, and I talk about the importance of the excision biopsy to get the full tumor to evaluate the depth, which is an important prognostic marker. So for now, we don't have early marker that we predict in a patient, even with a small lesion, and that's what we will need to define, who has a higher risk of bad prognostic. What are at an early stage, what are the melanoma who are going to progress quickly, as in contrast, what are the melanoma who are going to be fine after surgical excision. And that's something we will need to define, a biomarker of progression. So, I just want to finish and to illustrate, I think, two important questions that I get in consultation. And that's this example I was illustrating here. People coming with dozen or hundred or more, and who had already 10, 20, 30 excision. With the diagnostic of a dysplastic nevus, and scared because they believe it's a precancerous, which I believe it's not. Having multiple more and dysplastic more mean that you are at high risk of making one melanoma one day. It doesn't mean that all this melanoma that you have, each individual will become melanoma. Meaning that you're likely to make a melanoma, but most part of the time, when this happens, it's a new lesion that is going to appear and become a melanoma. So, meaning there is no, in my opinion, there is no reason to be excessively aggressive in terms of excision. Meaning, because that the big problem is these people come having like 10, 20 surgical excision with dysplastic device, but tell me also, all my mole look the same. What I'm going to do with the 100 remaining? Should I have all removed, which is quasi impossible. So that's where I think the collaboration is important between having regular dermatology consult who is going to follow the patient, and again, in my opinion, the most important factor is change between consultation. Is there a change? Do you have any new lesion, or any of your existing lesion has changed, grow in size, change in color? That's where the eye of the dermatologist is important, the patient who does self-examination, and the picture, which may be helpful in some case, a whole body photograph, which need to be compared. So the change will be a critical factor. And if needed, in some specific case, the surgical excision will be performed. But really, I really discourage to be very aggressive and go after all this, which is impossible. That's increase the stress, and most part of the lesion we already know what will be the diagnosis. There could be a dysplastic nevus, and a number of patients are really very stressed and come to the consult with this, 20 pathological reports showing dysplastic nevi after dysplastic event. Really, so I think that's an important notion to do. To know dysplastic doesn't mean melanoma or precancerous. So now, how to prevent melanoma? And as John Kirkwood mentioned, I think the most important factor is sun protection. So, and I will stress the notion of limited sun exposure, which needs to childhood. So this is education, not only for yourself, but for your parents and the children. You really, at an early age, have to stress limited sun exposure. Limited sun exposure means not excessive sun exposure between 10 a.m. and 2 p.m. So not spending hours and hours every day by the swimming pool or at the beach, and starting at an early age. If somebody has to be in the outdoor, in sun exposed area, the best sun protective method is clothes, so wear a t-shirt. So what about the sunscreen? And we have so many questions about sunscreen, so should I use them? What SPF? And so sunscreen are good. So, and SPF, you have different opinion, but I think above 15 is good. But I think that sunscreen is good if they are not a mean to extend sun exposure. Meaning I think it's bad to believe that, to use a sunscreen and extend your exposure on the sun. And that's, you have to limit your sun exposure at the first, don't spend hours. And then when you are in sun exposed area, use a sunscreen. But don't use a sunscreen as a way to say, hey, that's fine, I'm going to spend all my day by the swimming pool, in a swimming suit. That is not good. Meaning the exposure to the UV is going to be really important, and you're going to defeat the purpose. So limit sun exposure, clothes is the best way. When you are to be in sun exposed area, use the sunscreen on your face and arms to complete, to limit the sun exposure. That's the way to use the sunscreen. In patients and maybe in children, and sometimes it's a problem depending on the location of the large moles, but I think surgical excision is important to remove the cogito. So that's basically all I wanted to remind you in terms of early detection. I don't know if I have to take any question now or later on.
I can do them after.
Okay.